I am so excited to be here with you tonight. Welcome to the Life with Cancer Men's Sexual Health Series. My name is Lauren. I am one of the therapists that specializes in sexual health here at Life with Cancer, and just thrilled to be kicking off this series with you tonight. Before we get started with our guest speaker, I'm going to share just a little bit about the program and about Life with Cancer. We want to first start off with a thank you. We're so grateful to the Cancer Action Coalition of Virginia and the Centers for Disease Control for the grant awarded to us for this program. So thank you to CACFI and the CDC. Life with Cancer is part of Inova Cancer here in Northern Virginia. We provide education and psychosocial support to all individuals impacted by cancer, from diagnosis and beyond, through evidence-based holistic care at no cost, no matter where treatment is received. Our mission is to enhance the quality of life of those affected by cancer by providing this evidence-based education, support, and programs. We offer several different group programs, from support groups to educational programs and series such as this, mindfulness programs, fitness programs, and more. And we also offer additional sexual health programming, such as our men's sexual health support group, Sex and Cancer for Men. We do want to make a quick note that the information presented today is for informational and educational purposes only and is not to be treated as medical advice. We also want to let you know that during this presentation, we please request that you send those questions through the Q&A box, and we will address questions at the end of the presentation this evening. I'm going to go ahead and stop sharing to introduce our amazing speaker today. I'm so excited to have you here with us. My mouse is going to work here for me. Ken Mitchell is a certified physician associate with 29 years of clinical experience overall and with over 26 years of experience in male sexual dysfunction and infertility. Ken received his master's in physician assistant studies at the University of Nebraska Physician Assistant Program. He is currently a fellow of the American Academy of Physician Associates, the Urological Association of Physician Assistants, associate member of the Sexual Medicine Society of North America, board member at large for the American Society of Men's Health, and section editor for the Journal of Reviews in Urology. Ken was inducted into the Pi Alpha Physician Assistant National Honor Society in 2016 and is the 2023 recipient of the American Urological Association APP of the Year and the 2023-2024 Plan of Care Network Top PA in America Urology recipient. Ken practices at Erlanger Urology Men's Health and Reproductive Medicine Clinic in Chattanooga and is the co-founder and CEO of Gynecology Men's Health Association, a nonprofit organization dedicated to men's health provider training, consumer education, health promotion, and research. Ken, we are thrilled to have you here with us tonight. I will hand it over to you to take it away.
Well, thank you so much, Lauren. Again, I really appreciate the opportunity. Big fan of every cancer institute that's willing to not just cure cancer, but also treat those the folks for living with cancer, which been around long enough to know where that really wasn't addressed like it should have been, and now that it is, it's wonderful to be a part of that movement and that growth in that area. So again, thank you for having me. Thank you for having the program. I think it's tremendous, and I hope to be able to just shed a little bit of light on our world and again and how we look at treating sexual dysfunction after cancer treatment. So I'm going to go ahead and share my slides here. Just bear with me for a second. And should be good to go. All right. So again, Ken Mitchell, I'm physician associate. We just changed our name last year, so we used to be physician assistant. So I got to get used to saying that. As Lauren pointed out, I am co-founder and CEO of Gynecology Men's Health, and also practice in the male reproductive and sexual health clinic, Department of Urology at Erlanger in Chattanooga, Tennessee. And so, again, a little bit about my background. I started in what is now referred to as survivorship back in 2005. I was asked to start a program at a large urology practice in the Twin Cities of Minnesota. And I had was fortunate to have just really been exposed to a lot of people who shared their insights on one provider sharing their insights of what they felt was lacking in the care that was provided for the patients. But then I also was able to go visit support groups and talk with patients. Also, sorry about that. And so again, and also talk to therapists as well. Again, they were very, very helpful in helping me learn more about really what we needed to do as healthcare providers to help our patients with the treatment itself, and also how to live with things that can occur following treatment. So um, my journey really I like to highlight it with one instance. So there was a book that I was received. I actually got this from a patient, and you see the title, it says "You Can't Make Love If You're Dead," and you see the individual there that wrote it, Leon Prochnik. This gentleman was someone who was diagnosed with prostate cancer right at about the advent of uh, nerve sparing procedures. And he was given a diagnosis, told he's going to have treatment, and he was very concerned. This guy was a screenwriter in Hollywood, and he had a young wife. He was very concerned about the side effects of the treatment at the time, and he was really didn't know what to do, and he sought all kinds of alternative therapies and things that he thought would help him avoid undergoing surgery or any type of chemotherapy. Again, with the concern of, in particular, sexual dysfunction. And so, Mr. Prochnik, his family were Polish immigrants, and he was sharing his diagnosis and what was going on in his life with his aunt. And he said that in talking with her, he said, I'm really worried about this treatment for my cancer, and I don't know what I'm going to do if I get this treatment done, and I can't perform sexually. And her answer to him was, "You can't make love if you're dead." And I said, "Wow." And he said, yeah, he ran with that from then on. I chased this guy down for about 3 years, and I finally found him, met him, and we had lunch. And I wish he was still doing what he did, but he really shed some really good light and insight into how concerning this is for men. And so, you know, men really are so concerned that really, and it has been historically shown, they would even consider canceling and or postponing their cancer treatments for fear of the side effects of the treatment afterwards. And so, again, this book just does such a wonderful job of illustrating that. Find copies if you can. I've got three. It's no longer in print, but I know there's still some flying around out there. So if you can grab one, please do. So we look at the patient and partner concerns. There was a study that was performed back in the early 2000s, and there they noted that partners reported there was increased stress related to the diagnosis and treatment. However, there was no change or positive change in the relationship after the diagnosis and treatment. So even though this was a concern oftentimes for the patient who, again, undergoing prostate cancer treatment, the partners in most cases were very supportive. And again, it brought them closer together. And again, another thing that was very controversial at the time was that 91% of patients in this study showed wanted information on their sexual dysfunction or the possibility of it and how it could be treated, either at the time of or before the treatment occurred. And then many of the men, because this didn't occur, they elected to really not follow through with any of these things. Just said, "Well, I'm just going to give up and just say, you know what, it's not worth it because it's not going to get better no matter what." And so there's no doubt, even today, still, although the treatments with the robotic surgery and the like have certainly had a positive impact on development of sexual dysfunction after treatment, it still is the most negative, has the most negative impact on the quality of life today. Now, sexual dysfunction actually, it's not just erectile dysfunction. There are a number of different things that can occur following treatment for prostate cancer. And so we're all familiar with the erectile dysfunction, but the penile length alterations, many guys will tell you, and I'll share more with you what we did when I started the program in Minnesota was the penile length alteration, the shrinkage following the surgery. There's not a guy who's had prostate cancer surgery in particular who would tell you that, wow, they didn't tell me that was going to happen. And there's a reason for that. There's altered orgasmic sensation because you no longer have the ability to ejaculate. Again, you can also have associated urine leak with orgasm, and that's actually it's called climacturia, and that just requires a little bit of training because again things have been altered. Certainly, there's a lot of performance anxiety, and most that's followed by decreased libido. The guy can't again get an erection. He feels somehow like he's not able to perform, and therefore the sex drive typically is more psychological than hormonal, except for in the case where a patient might have undergone hormone therapy, or maybe a combination of both. Penile curvature has been shown to occur, Peyronie's disease in some men following treatment. Again, the exact mechanism there is really unknown. However, it's believed that afterwards, for guys who don't have complete restoration of their erectile function, it may be injury to the erectile tissue itself, having intercourse with without a firm erection. And then with all of that, of course, comes this perceived loss of manhood. And so there certainly is a psychological component that weighs heavily here, followed by just the psychological impact of the cancer diagnosis itself. And so when we look at this again, understanding that a guy can go into this procedure and again, literally overnight lose their function. And so it's very abrupt. I treat a lot of men for a lot of reasons for having erectile dysfunction, but this one is the one that typically has an exact day and time of when this occurred. And so again, that loss of those psychogenic erections, guys said, I see a pretty girl. I could be in a room full of pretty girls, and they said, I may be thinking about being aroused, but I don't feel anything happening. You're not having erections at night, and again, so that's something that is a big change. And so even understanding that when possible, again, depending upon the circumstance, which I'll go over more here later, this is something that resolves slowly, and it takes about 12 to 24 months or more to get full recovery when that's possible. And then, and full disclosure is a lot of the guys who come into these treatments had already suffered from some erectile dysfunction. And many years ago, when we first started doing this type of work, one of the mistakes that we made is we did not do a good job of assessing the erectile function prior to undergoing these treatments. And that had a direct impact on how well these guys were able to get back to a level of functionality that was satisfactory for them. Now, this slide's a little busy, but I put it on there for a reason, is because this is not just about practice prostatectomies. We have a lot of different ways that we can handle treatment of prostate cancer. And so even something as simple as androgen deprivation therapy. So those of you that might have been on Lupron, for example, where it lowered your testosterone, that could have a decrease in arousal, loss of libido, also can lead to erectile dysfunction, difficulty achieving an orgasm. Certainly the prostatectomy itself could be problematic, and as well as pelvic radiation, which oftentimes is in the past, can't really speak so much for that now, but in the past, the different radiation that was offered for treating prostate cancer has changed, got more precise these days. It came with its own issues. Again, it could cause nerve damage as well. Could also cause other problems with bowel, bladder dysfunction as well. And so a lot of those things can play a role. And so we're not just talking about prostatectomy. So when we use the term treatment. And so this is a real complex problem. And again, it happens overnight with this progressive or perception of worsening of symptoms. And so the physiological piece of it, they already mentioned about the penile length alterations, again, the sudden loss of ejaculation, Again, orgasm sensation has changed, the urine leak, the loss of morning and nighttime erections, and possible development of penile curvature in the case where the guy may have some restoration of their function with treatment. But there's no question there's this huge psychological impact. And I believe that what's different about a prostate cancer patient with erectile dysfunction or any type of cancer that, again, the sexual function can be impaired, that you are really dealing with a huge psychological component of I've got a diagnosis of cancer. I don't know how things are going to go. And then you do well with your treatment, if you will. You're feeling better. You're on the road to recovery and cure. However, though, now this big psychological weight comes into play, a second one, if you will, where you've got the sudden loss starts there. Now, if it's prostate cancer, the PSA surveillance anxiety, typically like you're hanging your hat on every PSA to make sure you're cured. Call it distraction, if you will, reasonable one. Again, I already mentioned the perceived loss of manhood, decreased libido anxiety. All those things play a role in it. So there's a lot of overlap there, this sexual and erectile dysfunction, and one cannot be addressed without addressing the other. And so very, very important that we think about it that way. Now, what we did in response to this is we developed these sexual function restoration protocols, and the first one that we called, at the group that I was at, was called the surgical impotence management strategy. Now, the reason we called it that, and it later became we kept one eye, but called the surgical incontinence and impotence management strategy, was we named the protocol as an acronym, but also named after a good friend of mine who lost his father to prostate cancer, and unfortunately was diagnosed late, and was not able to undergo any of the treatment that we were able to provide for our patients for prostate cancer before and after treatment. And so I dedicated what we did to his memory. But what we learned over time is that there has to be a mutual understanding. It's a choice. I recall having a patient, and what we did, which was a preoperative, we called it a class, where we met with all those individuals and their partners. And those individuals were already scheduled for, in most cases, prostatectomy or a combination of therapies. And so we talked to them about how their side effects if they were to have them, with erectile dysfunction, sexual dysfunction, incontinence, and then what we'd start doing about that. But I had an individual in the class who was visibly upset about his diagnosis, felt that being there amongst all the other men that were there, that it was a waste of time, and that nothing could be done, and he didn't know why they were doing this to him, and he was mad, audibly mad, in the middle of what we were doing in terms of giving talks and discussing all this treatment with all the others that were there. I remember my staff being concerned, saying that, this guy is mad, he's being disruptive. I don't know, maybe should we ask him to leave? And I remember saying, I said, look, I said, he is psychologically dealing with his diagnosis. He doesn't know what's going to happen. He's scared. I said, he may or may not come back, but if he's ready to come back, we're there to help him. And so we have to let him make that choice. And we can't have any say so in that at all. And really, we learned that the goal of treatment really is to help the patient and the partner return to baseline function when it's possible, or help them achieve a level of function with whatever means we have necessary that is satisfactory to both of them. And we want to utilize what we have available. So we've got medications, again, which most people are familiar with. We have several mechanical devices and even surgical options that we can do to help aid in restoring sexual function in the guys we take care of. And so it was also important to both my colleagues who were providing this care and also to the individuals that we were helping and their partners, that each and every person is unique and they recover at their own unique rate, if you will. Again, it's based upon a number of individual factors, and that they should not ever compare themselves, the patient, to another patient, and nor should we as providers compare somebody's improvement or lack thereof to another patient. Again, understanding that this is a unique individual, had unique circumstances. Although they may have undergone the same procedure, there are very, again, individual things that happen that decide how well these patients will recover. And so there were some key elements there that I think were really important. And one was that we addressed this prior to treatment. So I already mentioned we did this preoperative class. We had a very systematic approach to how we handled this, primarily because we knew exactly who was getting treatment. We knew what treatment they were getting. So we were privy to a lot of information. So our class was really devised to help the individuals that we were treating who were diagnosed with either prostate actually or bladder cancer in our facility. And we did educate both on sexual health issues and incontinence issues. Always invited and included the partner, spouse, significant others to accompany the patients. Many of them would come obviously to the class, but even to the follow-up appointments, we wanted to make sure that they were involved and that, again, we helped them through perceived setbacks and made sure that we helped them understand what progress they were making and, again, where they were headed. What was one thing that's really important in today's world is normalizing and adhering to a very non-threatening environment. I had whom I consider to be one of the greatest sex therapists, Michael Metz, was a friend of mine, wrote a lot of great books and articles on sexual health. He came and attended one of our classes, and he said that our class actually helped with the he called it the shoulder response, and that was if you walked in and your shoulders were high and tight, and you walked out and they were relaxed, and he said that's a good session. And he said not one person walked out of there without their shoulders down and relaxed, and people were smiling after being told they were going to have all these problems, but we had solutions for them. You wanted to give realistic treatment goals. So I was very clear about if you have these other problems or you're already suffering from erectile dysfunction, we're not interested in taking you back to a bad place, but it may be, and in many cases it was, the first time these treatments were offered to them to help their problems. And so sometimes guys came into with their diagnosis of prostate cancer with no treatment for sexual dysfunction that because of their cancer diagnosis, we were able to actually take them down a road to where we could help them become functional again. And so, in some cases, just because of the circumstances, they came out of treatment more functional than when they went into it. We wanted to also decrease anxiety, as I mentioned. And then we were very systematic in that we monitored the progress every 90 days, which I think is a good way to look at it. Most of the phases of healing post-operatively generally occur about every 90 days. Sometimes that can be more or less, but you can kind of bet on that and have realistic milestones that you want your patients to meet. You want to make sure that we have continued support with the patient and the partner through education throughout the care process. So making sure that if they're on medications, that they're doing okay with side effects and not have any issues there. Again, altering the way they take it as they're progressing through their treatment, and making sure they're getting the most out of, again, restoring their function or responding to whatever treatment that we're providing. And so, again, these core principles, again, I think is really important. Is also to identify who is motivated, and motivation is an interesting thing because motivation can be it can ebb and flow throughout the healing process, and you know there can be setbacks, and that can decrease one's motivation, and people can feel inclined to give up at times. But we want to make sure that we're being encouraging, and even at the outset, make sure they're motivated and help them remain motivated to regain a level of function that, again, they deem satisfactory. Keeping your word is extremely important. In looking at other places and how they did things, not as a critique, but I wanted to make sure that, given the sensitive and personal nature of this, I want to make sure that we honored everything that we did, both in word and deed, and so patients could count on that as well. And then, as I already mentioned, using proven tools and therapies sometimes in a manner that you might not see on commercials or things like that, but we know they can be used in other ways as more of a therapeutic functional tool, if you will, not so much as a treatment like one would see on TV and ads. And again, present realistic expectations. Like I said, if you go into it, you have bad erectile function or sexual function going into treatment, then it's not really a good idea to take you back there. So we want to say, okay, our attention is going to be more towards helping you regain function in other ways. And so throughout all of that, shared decision-making principles have to be used, and that is the extent of which uh, therapies that you're willing to participate in that you want to do, and then how long you're going to have to do it. And those are things that are constantly discussed over and over again to make sure that we're staying on point. So, what kind of expectations can one have or should have? As I already mentioned, about 12 to 24 months is typical. You're going to have some people sooner, but very rarely you have somebody be fully back to their baseline function in less than a year. But you should see them progressing there slowly. But again, some may take up to 2 years. And again, depending upon the treatment and what sort of issues might have come along with the treatment. So again, these multiple factors, as already mentioned, play a big role. One of the things that I'm a big advocate of talking about with the guys that we take care of is that your health status is extremely important. So if you're not exercising, if you're not eating well, these things will play a role in how you heal from anything. And so if you want to again have a uneventful recovery, if you want to make sure that you get the most out of your treatment, not just for the sexual dysfunction, but your cancer treatment, do things to help maintain and improve your health status. Managing your emotional psychological state. I'm a big fan of making sure that the guys and the partners that we take care of, that they are in a good mental state, that they feel good emotionally, psychologically, spiritually, that they feel good about their therapies, and again, they're actively participating in full with their mind, body, and their soul. Um, the medications, again, I already mentioned, although we use them in a therapeutic fashion, probably one of the toughest things we had to manage early on with this was helping guys understand that, 3 months after surgery and we've got you taking, one of the oral agents like Viagra or Cialis or Levitra, and you're taking them and you're like, oh, and I took it and nothing happened. And I said, no, nothing is supposed to happen yet. And we go over in great detail about that, which I'm going to reserve for tonight, unless you ask me in the Q&A, because we got some great speakers coming down the road who are going to talk about that in more detail. But the whole point of it is that we want to help, again, just like the analogy I like to give with these medications for the patients that we treat, is I'll say to them, hey guys, this is just like having knee surgery, which I've had a few of them. And I'll say, look, you can't just jump out of bed and then go out and run the next day. We have to do some things that preserve and restore the nerve function, get them firing again. And that's one of the things that we're using with the medications to help with that. And so again, I help them understand that, I wish my job was that easy. You could undergo cancer treatment and I could just give you a Viagra or a Cialis or Levitra and you're magically just doing well. That would be great. And then eventually you don't have to do anything at all. That would be even better. So, but just understanding that there's a difference in what we're trying to do to help restore function. And so in doing this, what I thought was really important, and some of them were unintended outcomes and consequences, is that one, I did want patients to feel empowered. One thing that I think is important as a healthcare provider is to encourage the patient to participate in their care. And so I often say this, anybody who's ever had me for a provider knows I'll tell them, here's what we're going to do, here's why we're going to do it. And then I'll say to them, because when it's all said and done and things are going well, I said, I don't want all the blame and I don't want all the credit either, if things are going well, because it'll take a team effort to get things better. But I want the patients and I want the people I take care of to feel empowered to do so. Structured guidance really is important, and the fact that that was provided, again, unaware that that's not always done or available to people, I think was extremely important. And probably more than anything else, and I know Lauren can speak to this, I know what the work that they do there is, we have so many great cures nowadays for treating cancer that you really have to consider life after surgery. There was a landmark paper talking about restoring erectile dysfunction in men following prostatectomies. And in that paper is Dr. Montorsi, back in the, I want to say early 90s, even, I believe is when the paper was published. And he made the comment that it's not enough to add years to someone's life when you treat them with cancer, but it's also important to address what happens afterwards and add life to their years. I don't think you could say it any better than that. Now, we did have some positive unintended consequences. As one is that over the years of doing the support group that we did, the education that we did preoperatively or pre-radiation or whatever we were doing, because we invited the significant others, they actually had developed their own prostate support group of, those who are the significant others of those undergoing prostate treatment, which I believe is still going on today. And I want to say that started sometime around 2008. And I believe it remains strong to this day. So really proud of that, but didn't plan on that happening. So I do want to address a couple other things. About all of this. Again, not sure everybody who's listening where they are in the spectrum of things, if they're just getting started or if they've had treatment already. But I can't say enough about the impact of the psychological impact on the physiologic impact. And so, how does all that work? And so, Dr. Barada wrote this paper, which again is another one of those papers that I hang my hat on, because one of the things that he talked about that was really important for not just for me as a healthcare provider to understand, but also for, to be full disclosure to those that we're taking care of, and that say, look, we understand that you've had this sudden loss of your erection, and with that comes frustration and worry, and that frustration and worry comes from a lot of places, obviously altered function, but societal ideology about where you should be as a man. All of that things becomes problematic, or my partner will leave me. Those kinds of things can creep into the mind of the individual who's suffering from sexual dysfunction. And so then there's this conscious focus on erection. So again, this is with treatment. We know you got a problem. We're going to, you're worried about it. Okay, now we're going to talk about it. So, so we're just sort of beating this horse, but then you're seeing these physiologic changes happen, your inhibits, your erections. And again, what happens really is you get this vicious circle, as we like to call it, where just the thought of treating it and the response not happening fast enough, will lead to increased psychological barriers. And I can tell you that the most important sex organ you have is your brain. And so if you've got an increase in your psychological barriers, more anxiety or more concerns, then that's going to be a problem, and that will lead to decrease in intercourse attempts. Joan Rivers used to have a joke about hallway sex, and I have to use the clean version of it, and that's just as hallway sex is when you walk across paths with each other in the hallway, and they say screw you, and I say no, screw you, and they said that's the way we engage, because we don't talk, we don't think about it, and communication breaks down. And that's probably when I say increased psychological barriers, is that silence that happens when somebody doesn't want to address this, because of concerns about not getting or making any progress. So that being said, um, I can't say enough about, utilizing sex therapists. Again, I was fortunate to have somebody that I consider to be one of the best in the world was in my backyard, and I had him at my disposal. But I really I can't say enough that everybody who's undergoing this type of treatment should have at least one encounter with some therapist throughout this. And so basically the way we look at it, and again, Lauren could probably tell you more about this, but the way at least it's been explained to me is we do want to do that cognitive restructuring, which is simply want to modify those attitudes and beliefs that you might have had going into your treatment about sexuality. We want to make sure that we're good there. And then hopefully with that we'll reduce the anxiety, and again, worried about performance anxiety. think of it more like goal achievement rather than, not goal failures, if you will. And then in some cases, we got to change things. In the case where we're talking about individuals that we can't restore their baseline function, they're going to have to change the way they do things. And we want them to embrace that. And so we want to increase sexual options. Again, the speaker you're going to have a few weeks is going to give you a great, great lecture on that, Amy Perlman. And she'll tell you a lot more about this. And again, she's great. And the hope is at the end of the day, there'll be more relationship enhancement and that'll improve the communication and intimacy. And so, as I mentioned in the earlier slide, as it was illustrated in the study, was that most people, when they're having really good, sexual activity, if they have a good sex life, there's usually not a lot of discussion or language around what that's like. And unfortunately, in some cases, what happens is many of the individuals find themselves having to talk about their sex life when things are not going well, and not enough discussion about when things were going right. And so, in best case scenario, in light of the diagnosis, a lot of times you can see some relationship enhancement. As I showed again in the previous study, that there's an improvement in intimacy and the relationship because things are different. And again, partnering with one another in this way to again achieve good goals. So, um, one of the things I wanted to touch on was like, so why is this so challenging? Why is this so difficult? Why do so many men over the, on nearly 30 years I've been doing this, had difficulty with um, even engaging or even doing anything about this? And I will tell you it's primarily because there are a lot of challenges associated with the term men's health. And so there's going to be a little bit of a lighthearted portion I'm about to share with you, but I wanted to mention some very serious things in the hope that you could understand even why I do what I do, why I do the gynecology thing, is because we needed to take credible information and get away from what I like to think is the stigma or this ideology about sexual health. And I can't stress enough that when you interplay those things with a diagnosis of cancer and restoring function, you can put unnecessarily extra pressure on anybody who's again trying to help restore function both for that individual and their partner. And so this is what, again, I can tell you, and I've shared this at many professional lectures myself. So the problem is that men's health has been misdefined. There really is an actual definition. The World Health Organization had come up with a definition back in the 1940s, and unfortunately, it's just been mixed up with this sort of idea that here's the real male brain. That all guys do when they talk about men's health is all they do is they think about sex, and then at some ludicrous speed, then a guy is going to get an erection, and that's all they care about. And that's what they consider to be men's health. So that's all the testosterone, it's all the ED, all that stuff. That is what men's health is. Well, that is couldn't be more incorrect because the reality is, when you look at the reasons men have erectile dysfunction or sexual dysfunction, we've already talked about cancer diagnosis, but heart disease, all these things that are problematic that can kill a man are the things that are in fact the underlying causes of sexual dysfunction that are not addressed in the mainstream marketing of a lot of the centers as well as the treatments that are available. And so reality is, I put this article, even though this article is now 24 years old, I guess I'm smacking my own, that is us males, is that we are not very good. We don't go to the doctor. About still 1 in 3 men don't have a regular doctor, and about a quarter will wait as long as possible. And so when we see controversial things like PSA testing and things like that become a problem, men don't need additional reasons to not seek care of any kind. And so we know early detection in cancer is again means a better prognosis. And so again, things like this are really important. And just to show you the scope, so I just want to give you a little bit of another illustration of what I see going on here. So Men's Health magazine, interestingly enough, men are really bad about prevention, but I didn't know this until I was doing research, is that Men's Health magazine was actually a spin-off of Prevention magazine back in 1986. They did a supplement actually, and then they officially launched the publication in 1988. And now it used to be published 10 times a year, but now it's only out 6 times a year. And it's published by Rodale, which is part of Hearst Publishing. It has about 13 plus million readers, gives you all this information. Most of the time, you have celebrities and somebody showing their six pack abs on the cover. It is, again, very, very, very popular publication. But what's really interesting to me are the last four bullet points there is that nearly half of the readers are female. It is a global publication, so it's got a readership of 35, plus million, and just even the U.S. circulation alone exceeds 1.8 million. And so it's very interesting when we look at this, and we know that men's health and men do better, whether we're talking about general health or cancer, when they have a partner, male or female, as the case may be, that is supportive of them. But what's interesting about that, and why do I bring this up? Many of you have undergone treatment for cancer, and many of you have also sought treatment for your sexual health. And many of the things that we ask or try to get you to utilize or want you to utilize to help with your treatment are being not covered by your insurance companies. And so, just to give you an idea of the scope of the problem, again, further, is that back in 2015, Men's Health magazine actually did create a very worthwhile petition to help create the Office of Men's Health in Washington, and that required 125,000 signatures. And unfortunately, they had to archive it because even with that huge readership, they only got 1,500 signatures. Now, I do strongly believe this, that if they did it today, given that they have nearly half of their readership are females, the females would probably be the ones that give the overwhelming majority of the signatures to make this happen. And the Office of Men's Health would hopefully become a reality. But in 2024, it still does not exist. And the only place that you can find it really is in the Office of Women's Health, which has been around since 1991. It is part of the Department of Health. It is under the Deputy Assistant Secretary for Health, and they chair the Coordinating Committee on Women's Health, which was formed all the way back in 1984. And unfortunately, fortunately, again, women, fortunately, there to help take care of us guys. It is the only place, if you go to the womenshealth.gov, is the only place you're going to find any government information about men's health outside of statistics about the problem. And so this is something that, again, I'm very passionate about. And I think all the men that I've taken care of and I've watched things come and go with medication coverage, vacuum device coverage, all those things that have gone away, I think are all part of this big picture of the misunderstanding of what men's health is. And therefore, it's put a stain on, if you will, how people view it. And it's led to a lot of men not being able to get care that they much deserve and should get following treatment for any reason, and certainly for cancer patients to get treatment for their sexual dysfunction. Now, believe it or not, that is all I have because on purpose, like I said, you've got some great speakers coming up, who many of whom I know personally, who are going to delve into more, if you will, details about some of these things that are available to help, and talk more about how you can obtain those things outside of a systematic treatment that we and I have provided to patients over the years. With that, I believe I will stop sharing. Lauren's going to take Q&A, but if anybody has any questions, this is up here. That's my email. Some people think I'm crazy when I do this, but I do it anyway. But I do my best to answer them as best as I can. So I will say you'll get a response, but be patient with me if it takes a while. Sometimes I get hit pretty hard. And then that's our website. And I only put that up there because right now we're in the process of building the consumer education stuff. And so hoping that we'll get that done soon. And I can promise you there'll be a lot of information about, again, some of the stuff that you hear from the coming speakers in the next few weeks about the treatments for sexual dysfunction. So on that note, I will stop sharing and get back to me. All right.
Thank you so much for that, Ken. We're so grateful for your wealth of knowledge. We don't have any questions in the Q&A at the moment, but we'll give it a few minutes. If anybody has any questions, please feel free to put them in the Q&A, and we'll give Ken a chance to answer some of those.
I'm impressed by the turnout. It's very good for a first time, so I'm really glad. So again, I hope what I had to say was helpful to a lot of individuals and that tuned in. And you, like I said, this is great that you're doing it. I mean, I'd probably say still to this day, after all these years, that's still the biggest thing that I hear is people saying, "Boy, there's nobody talking about this." So you're giving 8 opportunities for people to hear about this, which I think is fabulous. So kudos to you and Inova and the people that gave you the grant. I think it's tremendous. So,
Thank you so much. So one of the questions is, what's
there we
the
go.
reason that sexual health issues are not part of many networks?
So I've done some work with the company, and I will tell you that I think it is a combination of things. One is it's always focused on the treatment, curing cancer. So I think that's one issue when you talk about the networks. And the other thing is if you're talking about like your health network, um, primarily because insurance just doesn't cover a lot of this stuff, and so a lot of health networks just don't provide the care. They're like going, you have to find it on your own. And a lot of us are always trying to figure out ways to help figure it out. So um,
Another question. One of your charts stated that it takes 12 to 24 months to begin to regain function. Asking for you to elaborate on that timing if someone has had EBT but continues to take Lupron injection.
right. So that's kind of what I was talking about. So there's a great example of how um, continued Lupron injections is by far just going to keep suppressing your testosterone. It's going to be very difficult for you to at least drive an erection. Interestingly enough, though, a lot of people think that testosterone is a reason to get an erection, but it's like actually no, it's the reason you'll want one. But in and of itself, it doesn't, giving a guy normal testosterone helps, but it's not the only factor. So one can get an erection without it, but the desire to have one and to be aroused, that's where it'll be difficult. So that's kind of a weird disconnect to have. So sure.
Having the two pieces together is really kind of what
Hmm.
makes it happen.
Correct. So
Do you encourage men post prostatectomy with ED to take nitrous oxide supplement?
boy, good question. So without going into all the physiology, nitric oxide both is the signal to the nerve signal. It carries that part of that process. It also is responsible for the dilation of the blood vessel for the blood flow. So the way I like to describe nitric oxide supplements, and I'm not going to tell you how much to take or anything like that. I suggest though, if you're taking so much that your face is constantly red, that's probably too much. However, but if it does have an additive effect on the nerve signal as well as the response to the blood vessel itself. And so we do recommend it. We have some that we do specific ones that we recommend. So like L-arginine is probably one that most people will get and take that with it, but for sure.
So it would be something you'd consider and encourage talking to your provider to learn more for your specific case.
Yeah.
It's been my experience that urologists are the last place to go for advice. They're too busy and take a deep dive too busy to take a deep dive into this. Where should a recently diagnosed person go for advice to deal with the things you're talking about?
All right, so that's tough to because knowing where you are. If I knew where you were, I'd probably give you a very precise answer. But most of the practices now, and one of the things that we do with our with gynecology is that we're trying to train more PAs and like myself and nurse practitioners to be in the office to help provide the care and drive and basically guide this type of care. So depending on where you are, it's a question to ask. Do you have somebody who's going to be dedicated to helping me with the sexual dysfunction?
I think we lost your sound.
There you go. Sorry. I knew I lost my audio. But yeah, that's what you really want to do. And that's I would love to tell you I know that that's just the norm, but it's just not. But that's a question to ask. And if you find something that works for you regionally, if that can both give you cancer treatment, or if you could find a urology practice that specializes in sexual dysfunction, that would be, you can use that as an adjunct, if you will, to what you're doing.
You. Are there any differences between recovery seen between prostatectomy versus radiation treatments?
No, I would, again, if somebody has to deal with that, again, it just, there's so many factors in that. Again, nerve sparing, how you heal, where the radiation, where the cancer is, where they have to aim the radiation. I mean, there's so many things that play a role in that. So I don't give advice on the best cancer treatment. I tell people all the time, I said, you get whatever is the best treatment. You talk to your urologist or your oncologist, and then by all means, I'll help you. And any of us who do this will help you with the aftermath, no matter what it is. So, but we can't help you if you're not here. That's the way we look at it. So you do what's best for the cure, and then we can deal with the other stuff after.
Can anything be done concerning the post-operative shrinkage? The section of the urethra that is removed during prostatectomy has reduced my length by 2 inches. Attempts at stretching the penis result in loose skin that used to be erectable.
So it's interesting. So the urethra doesn't have that, believe it, has nothing to do with it. It's the lack of erection and nerve signal causes the tissue to atrophy, just like if your arm was tied behind your back. For any length of time, the muscle atrophies, and it's the penile tissue actually is smooth muscle. And so that's the issue. So if you're using a vacuum device, or you might want to look at a traction device, which might be a little bit better so you don't get so much of the loose skin. That might help with that. But that's the best thing to do, is to use some type of a device that stretches the tissue while you're working on the nerve function. So
Great thought. Great talk. Thank you so
yeah.
much. Do you have any thoughts on people who underwent cancer treatment but now do not have a sexual partner? Is seeking sexual dysfunction treatment better to do now? Or what's the best way to approach this while partnerless? Honestly, part of me is a little concerned, a little bit doesn't want to even start a new relationship because of sexual dysfunction. So like, when is the timing right?
Right. So this is one guy's opinion. I'm going to assume that, Lauren, you're going to agree with me on what I'm about to say. You want to make sure that you're ready to go. You don't want to go in a relationship and say, "Oh, now I'm going to do something." You want to make sure that you're a fully functioning, happy individual, confident individual who wants to be able to enter in a relationship knowing that they have a way to be functional and they can openly discuss that with their partner. I think is the best thing to do. If you do it after the fact, I think it's tough. That's just, again, my experience has been, you really connect with somebody and then you want to be intimate with them, and now it's a desperation type thing. The clock is ticking. If I do this whatever I have to do to be intimate, and you've got it down and you're comfortable with it, you can have that discussion with your partner, and then you can be intimate and not worry about it. But man, if you're gonna try to do it after the fact, that's tough. That's a tough sell. So,
Like doing it for you and increasing confidence and comfort with your own self,
mhm.
now, regardless of when that partner comes into the picture in the future.
Yep, yep, you'll be ready to go, and that's really important. I think, so you want to connect with somebody at every level that you can and be able to do that, not do it after the fact. So.
Any suggestions regarding three-piece penile implants following radical prostatectomy, and how quickly is it safe to consider an implant?
I'm going to give you a brief answer, but I'm going to save that for one of you've got two upcoming speakers who are going to give you a really good answer on that one. But so again, I've been around implants for a long time. I think the three pieces are the best. Again, it's one guy's opinion. So if you're asking an opinion, I will give you that. It's the most natural appearing, is the most naturally functional, and they also last the longest. And so on average, about 9 to 10 years. I think when is it safe to do it really again depends upon what treatment you've had, one, and then second, um, uh, you know, where are you at in terms of recovery from all those treatments that you've had? So that's really the timing wise on all that. So most people though really won't be offered the surgery itself for at least 12 months after whatever treatment you've had for prostatectomy or radiation or anything like that. And even that will decide, again, which therapy you had will do it. So yeah.
It's been over 5 years since treatment, radiation. Is it too late to work on length?
No, never, never. Um, so think about it this way: if you had a stiff hamstring and you couldn't touch your toes, Um, you haven't been to touch your toes in 20 years. Does that mean you can never do it? No. Can you run and jump? Not with a stiff hamstring. So you can work on that at any point. Because the point is you want to have a nerve signal that can tell a muscle that's now responsive to function again. And so no, it's never too late. And in fact, it'll decide how you respond to anything, honestly, even if it means you've got to, take a pill or what have you. So um, that would be no, no. In fact, when Amy comes on, she'll tell you. She may even quote me. She knows how to say, "You by any means necessary," is the way I talk about that. So,
Do you have opinions about specific vacuum devices?
only opinion I have is medically or FDA approved or FDA cleared devices. What I would recommend. So I would not recommend cheap adult store toys kind of a thing, but I would get an FDA approved or FDA cleared device.
That's our last question. We'll give it another minute or so to see if any others pop in here.
All right,
Thank you so much for
no problem.
not only your presentation, but being able to dive in and answer all
No,
these
those are
questions.
yeah,
So
great questions. Actually, like I said, you and I'm just gonna say I know who's coming up, and I would encourage those of you that heard me tonight, please tune into the next ones because you're gonna get more and more detail. I mean, each one does build upon the other. I think it's tremendous. So, as I said, kudos to you. This is really good.
thank you so much.
So, you know,
It doesn't look like we have any other questions. We had one comment that said no questions, but really enjoyed the information received. So, thank you so much for being here with us. We are incredibly grateful for your time, your expertise, and certainly appreciate all that you've given us this evening.
all right, you're most welcome. And again, thank you for the opportunity and good luck to those who attended. And like I said, you got my information. If you feel free to reach out. The individual who asked about, if he wants to reach out and tell me where he is, chances are I know somebody somewhere nearby. So,
Well connected.
yes. So,
Well, thank you so much, everyone, for coming tonight. Life with Cancer is so grateful to have you and to launch this series. Our next one will be on that's actually not accurate, on March 6th, on sexual health and an overview with Dr. Rachel Rubin. So incredibly excited to see you all back here again in about a week or two. So take care, everyone. Thank you so much.
All right. Thanks, Lauren.